Great. Hi, everybody. I'm Susan McDaniel, and it's an honor and a pleasure to be here with you today and participate in these exciting and important discussions. So the University of Rochester Primary Care Family Psychology Postdoctoral Fellowship integrates several theories and their applications to improve the health and mental health outcomes of children and their families. Several important pioneers at the University of Rochester really laid the foundation for this work in the 1970s. They were influenced by systems theory and recognized early on that health isn't only determined by biological, but also psychological and social factors. And these men I was fortunate that they were my mentors. George Engel, an internist whose appointment was in psychiatry, described a biopsychosocial approach in the journal Science in 1977. Lyman Wen, a psychologist and psychiatrist, was the chair of psychiatry and one of several mental health professionals who started family therapy in the US in the 70s. And Bob Haggerty was the chair of pediatrics, and Bob focused on children within their communities during the same time period. So my work on medical family therapy and integrated primary care synthesizes really the work of all these men. In the early 80s, with family physician Tom Campbell, I worked to develop a practical primary care application of family systems approaches for the family medicine residents that include assessing for behavioral and mental health problems and making referrals using the patient and family's language and health beliefs. The problem came in not being able to get my mental health professional friends to communicate with the residents about their patients' care. So in 1985, prior to any regulations that would hinder us, and really more out of desperation than vision, Tom and I asked, I wonder if it could work to provide behavioral health services in primary care clinics. We hired a family psychologist, and the results were astonishing. The patients, adults and children, loved it. They felt comfortable coming to their physician's office for care, so it made a big difference with regard to stigma, and their professional communications problems melted away as clinicians rubbed shoulders with each other on a daily basis. From that day forward, we implemented a biopsychosocial approach to health and illness through integrated primary care. The demand for services grew so quickly that we hired 2 more psychologists the next year to work and teach in family medicine. And a year later, we started our 2-year postdoctoral fellowships, one for family physicians in family systems medicine, and a primary care family psychology fellowship for psychologists. The model includes interprofessional family systems medicine seminar with the psychology fellows and the family medicine residents during the residents' 5-month psychosocial rotation, where we use our curriculum, family-oriented primary care, as a text in order to make sure that we've developed a shared mental model of biopsychosocial systems work. The seminar is followed each week by having residents bring in families from their practice to work on assessment and interviewing skills with children and their families, with the seminar group participating from behind a one-way mirror. Throughout the 2 years of training, the psychology fellows also participate in interprofessional teams, seeing patients in the clinic alongside the residents and faculty. So you can see here that the psychology fellows develop expertise through training in primary care for 2 years. The family medicine residents get 5 months of training in psychosocial medicine, which is about 4 months more than most residencies. And the master's students in marriage and family therapy have a practicum placement, gaining experience seeing primary care patients for 200 hours. Then there's the discipline-specific training in order to develop the competencies involved in being, say, a family physician or a family psychologist. The psychology fellows, for example, have intensive family therapy training over their 2 years, including family therapy seminars weekly, as well as individual supervision and weekly live supervision groups. So this is our curriculum for them. Learning to think systemically and biopsychosocially and provide medical family therapy is a complex set of skills to develop. It takes time, support, and guidance to learn. Each June, we have a medical family therapy and integrated care intensive for 5 days, open to everyone, draws interprofessional participants from all levels of experience, from students to faculty running programs on integrated care. It consists of talks that provide knowledge and inspiration and small groups that provide intensive learning, skill development, and consultation. I'm particularly interested in 3 outcomes from the Fellows Family Therapy Training. Since they come to us already having some child psychology and pediatric skills, I want to make sure all of them gain excellent adult, couple, and family therapy skills, that none of them leave saying what I too often hear from more traditionally child-trained professionals, which is, I love working with the children. I just can't stand working with their parents. This statement reveals a lack of understanding about how intertwined a child's strengths and challenges are with those of his or her family and community. The second outcome I want them to develop is the application of family systems concepts and skills to facilitating team-based care and its effectiveness. And finally, we want the fellows to learn to supervise the master's level clinicians. For us, it's MFTs and care managers. So this model of psychology fellowship in family medicine has worked so well that we adapted it to pediatrics, geriatrics, neurology and epilepsy, OBGYN and fertility, and surgery. So I want to focus the rest of my time on our pediatric family psychology fellowship training. Pediatrics at Rochester General Hospital is part of the university's Department of Pediatrics. So in 1996, I negotiated with them to hire one of my senior psychology faculty to educate and train the pediatric residents and supervise a family psychology fellow in their ambulatory underserved clinic. 20 years later, 3 psychology faculty and 2 psychology fellows work at RGH. All our fellows, including those in pediatrics, come over to family medicine for the 5-month Family Systems Medicine Seminar to develop their understanding of family-oriented primary care. And there's also a pediatrics-only focused book based on families called The Family is the Patient by Almond and Tanner. The Family Psychology Fellows also do a case-based seminar with the Family Medicine Fellows, and they attend and sometimes facilitate a 2 to 3 30-minute seminars per week with the pediatric residents. These seminars occur every weekday prior to all of them working in their clinical practice. So they do brief child-focused behavioral interventions and psychotherapy. They do behavioral checkups as part of well-child visits before the child's seen by the pediatricians. And the fellows also participate in medical group visits to support breastfeeding for new mothers. You can see on this slide that the pediatric residents get a month of developmental and behavioral pediatrics, plus these weekly seminars before their continuity clinic. The Master's in Marriage and Family Therapy students just observe in this clinic for 18 hours, so they get some exposure to integrated pediatric care. So to summarize the training, both pediatric and psychology fellows get disciplinary-specific education and interprofessional training to develop a shared mental model that we call a biopsychosocial systems approach. We also work hard to model and discuss what modern dancer Twyla Tharp calls the collaborative habit. In addition to learning what each other is good for, this consists of increased self-awareness, moving from me to we, increasing each other's contributions to the team, surfacing and managing conflict, learning the latest in team effectiveness research, and practicing mindfulness training. Finally, there's clinical work where it all comes together, working with children and families as part of interprofessional teams. The qualitative evaluations of the fellowship by the fellows are always outstanding, but more systematic are the outcomes on the pediatric residents after graduation. So a study was made easy because we have a single pediatric residency in Rochester, and it assigns residents to their 3-year ambulatory continuity clinic in one of two places: the University Ambulatory Clinic, which has traditional assessment and referral for behavioral health problems, or did when we did the study, and the Integrated Primary Care Clinic at Rochester General, where our psychology fellows train. In a study that resulted in 2 papers in academic medicine, 245 alumni of the pediatric residency over a 15-year period from University of Rochester were surveyed, and 174, or 71%, responded. You can see here there's a very significant difference at the 001 level in comfort collaborating with mental health professionals for alumni who worked with psychology fellows in an integrated care practice as residents versus those with more traditional training. There was also a significant difference at the .02 level for pediatricians who trained with the psychology fellows, expressing greater comfort providing mental health care for their own patients. In terms of scaling up this model, a very difficult part is in training pediatric faculty to have strong collaborative psychosocial knowledge and skills, and especially to train psychology faculty to have strong family systems and integrated primary care skills. I will say there's a new off-the-shelf curriculum from APA's Division of Health Psychology with excellent slides on integrated primary care for psychology faculty who don't have this skill set but understand that their students need this preparation. So given the promise of improving access and quality for child outcomes, we really must work to develop professional and interprofessional approaches to education and training of a competent integrated pediatric primary care workforce. And I would say primary care pediatric and family psychology postdoctoral fellowships with interprofessional education and training are one answer. Thank you.